Now it's lobectomy and pneumonectomy, and this is one of the very common topic, one of the most commonly topic appearing in the Paces exam, and many of you will get either you will get a scar, thoracotomy scar, okay, and there is a DD for the thoracotomy scar, and mostly it is due to either lobectomy or pneumonectomy and sometimes lung transplant, okay. So when you find a scar in the examination, be very careful, inspect carefully, and because in the UK I have seen there is no keloid and scars are very faint, so you have to be very careful while inspecting the scars. And if it is female, then ask her, can you elevate your breast and examine under the breast as well, okay, because sometimes it extends up to that level also, and if you did not see, then it will leave a bad impression from your side, okay. So what is first of all, I will tell you the differential, like if you find a thoracotomy scar, so what differential should come into your mind, and examiners are also asking, okay, what are the differentials. So its differential include lobectomy, pneumonectomy, lung transplant, thoracoplasty, plombage therapy, lung volume reduction surgery, and bulectomy, okay. This is differential for the thoracotomy scar you can give. And if you find a small multiple scars like this, then there is a different differential for those. Like there can be biopsy scars and it is almost 4 centimeter. There can be chest drain scar, it is 2 centimeter. And there can be mediastinoscopy scar and VATS like video assisted thoracoscopic surgery, okay, and it is done for bulectomy, lung volume reduction surgeries, and for recurrent pleural effusions. So these small scars also you can find, so you have to see the length of the scar, like so that you can guess what is the underlying cause and what could be the underlying pathology. Now there are different causes for lobectomy, for pneumonectomy, and for lung transplant, okay. For pneumonectomy, three causes. One mnemonic is TBM. TBM. T stands for tuberculosis, B for bronchiectasis, and M for malignancy, okay. And there are indications for lobectomy. It includes again TBM like tuberculosis, malignancy, and bronchiectasis, like these three. And in addition you can find solitary pulmonary nodule, cystic fibrosis, and lung abscess, okay. These are the other indications for lobectomy. And so what are the indications for lung transplant? This also you should know. These are COPD, ILD, interstitial lung disease, pulmonary hypertension, cystic fibrosis, bronchiectasis, and malignancy, okay. And in case of COPD and ILD, single lung transplant can be, while in pulmonary hypertension and bronchiectasis they can be bilateral lung transplant, right. So these were the very important differentials which I wanted to share with you. Now in the exam, what could be the command? The command can be that patient presented with breathing difficulty, or like this, mainly breathing difficulty, okay. So now how you will present, like if there is a lobectomy, right. So how you will present, rest, I'm not starting from the hands and face, and this already I have explained while explaining other topics for the respiratory disease, and I have explained the signs for the respiratory disease as well. Whatever you find, you will describe those. Now I will present you findings on the chest. You will say that like one thing, if for lobectomy, if it is a lower or middle lobe, then trachea will not be shifted. Trachea will be central, mostly. And if it is upper lobe, then trachea will be shifted towards that side, right? So remember it. So now I will tell you the presentation of lobectomy. like on examination of this gentleman, whatever this all you know, I have explained lung fibrosis and other topics of respiratory system, how you have to present your respiratory case. Kindly listen to those audios. I will just present the chest findings. Okay, trachea is deviated to the left. There is a thoracotomy scar on the left side and upper lips are pulled in. Apex beat is displaced to the left and chest expansion is reduced in the left upper zone with dull percussion note and decreased breath sounds in the same area. And there is no peripheral edema or no signs of pulmonary hypertension. So on the basis of this, my diagnosis is patient is having left-sided lobectomy upper lobe, and my differentials include it could be pneumonectomy and other causes for lung the scar which I explained initially in the beginning. You can say that even, okay, because always you have to give the differential and then you will give your most likely diagnosis, right? So now I will tell you how to present pneumonectomy. In pneumonectomy, trachea is also shifted, okay? So trachea is shifted towards the left with a thoracotomy scar on the left side with a flattening of the left chest wall. Apex beat is displaced to the left. Chest expansion is reduced in the left side with dull percussion note throughout hemidiaphragm and absent breath sounds. And no signs of pulmonary hypertension. So on the basis of this, my diagnosis is patient is having left pneumonectomy and my differentials include this and this, okay? Like differentials for the thoracotomy scar you will give, which I described initially. So now there are few differences between lobectomy and pneumonectomy. This I will tell you. In pneumonectomy, trachea is shifted grossly. This you can identify, right? And chest expansion again is reduced throughout in the hemithorax. But as I have told you, you will not make your diagnosis on the chest expansion. Okay, how you will make your diagnosis of pneumonectomy? On the basis of scar, you will find a scar, thoracotomy scar, and okay, you can appreciate the tracheal shift. This also you can appreciate, and absent breath sounds. Okay, on the basis of this you will make your diagnosis. And how you will differentiate it from lobectomy? In lobectomy, trachea, if it is upper lobe lobectomy, trachea may be shifted. If it is lower lobe lobectomy, trachea may not be shifted, right? One difference is this. And second, in lobectomy, breath sounds are reduced. These are not absent, right? While in pneumonectomy, breath sounds are completely absent. So please remember this difference, right? And the apex beat, regarding apex beat, whatever side thoracotomy scar, it will be displaced towards that side. And over the deviated trachea, you can find the bronchial breathing, right? So these were the differences which examiner can ask, and you should know. You may, in the lobectomy or pneumonectomy or in the lung, in such cases you may find in other lung, in the diseased lung, the remnants of the previous disease. Like you can if on the right side there is thoracotomy scar, either lobectomy or pneumonectomy is done, then on the left side it is a diseased lung and you may find Krebs, you may find V's, bronchi. So this is also a possibility, okay? So examiner can ask you what could be the underlying cause. So on the basis of this you can tell the underlying cause. Like if you find Krebs and it doesn't clear, it clears up with coughing or changes its character with coughing, then you can expect bronchiectasis, right? And if patient is old age, cachectic with the lymphadenopathy, clubbing, smoking, nicotine staining, then you can guess that the cause could be underlying malignancy, okay? So one thing I want to tell you, examiners are always asking what could be the underlying cause. So this always you have to guess, okay? You cannot be 100% sure. So do not lose your confidence on the basis of this, that if examiners are asking the underlying cause and you are unable to tell, or you are unable to tell the exact cause, we cannot tell the exact cause on just examination of the patient, until unless signs are crystal clear, they are very clear. Okay, we can only guess that this could be the cause, bronchiectasis could be the cause, fibrosis could be the cause, malignancy could be the cause, right? Is it clear? So, and in respiratory system, one thing more I want to tell you, what you will get in respiratory system. Either you will get CREPS, right? And CREPS could be due to fibrosis or bronchiectasis. This you have to differentiate and identify the what is the underlying cause. And you can get pleural effusion like decreased breath sound and thoracotomy scar because of lobectomy, pneumonectomy or lung transplant. So these three things you can get in respiratory system, and respiratory system is not difficult. You should keep your ears open and pay a lot of attention to inspection and pay a lot of attention to auscultation, especially auscultation of the back, right? Then you cannot miss your diagnosis. Please like, share and subscribe my YouTube channel for more videos. Thank you.